So now we're basically up to the last two parts of obstetrics, and we'll be done with this, so we can jump into gynecology, which gynecology is a little easier than obstetrics in the sense that most of everything in gynecology is stuff we've already looked at in step one. So it should be a quicker chapter to get through. And then we can focus on another chapter that isn't really discussed heavily in step one, which is the pediatrics, which you can see from the breakdown over here that it's pretty much all of first aid, right? So it's got every single section all over again: genetics, heart disease, GIT, urology, immunology. So it's got every single section for itself in that own chapter, right? So we'll be doing all of that as fast as we can, and more sessions after Ramadan finishes. Hopefully next week is Eid, so we'll be done with the whole fasting thing for this year. So first thing we see here is a topic relevant to something we were wrapping up with last time, which involved the gestational diabetes, right? So we have just shoulder dystocia, uh, where you usually only get this when the baby's too big, right? So this affects here an average of 1% of all deliveries in the United States. Risk factors include obesity, diabetes, a history of macrosomic infant, and a history of prior shoulder dystocia. Diagnosed by a prolonged second stage of labor, recoil of the perineum, and lack of spontaneous restitution. So they have this thing called the turtle sign. That's what the recoil of the perineum is about. I haven't really seen that being described in a question, but it's gonna be pretty obvious when the question is leading you on to shoulder dystocia, because one of the most important things will be that the child is gonna be really big. Oh, let me see. Okay. So these are basically, like, you can already tell the criteria for what it takes to diagnose this is not really anything crazy. And then they just jump right to treatment. In the event of dystocia, the following maneuvers may be attempted. And then they have pictures to show you some of the maneuvers and stuff. But again, this table does more to tell you about. This table tells you more about shoulder dystocia than the book itself. Like, this is really all they're saying here. Um, you know, a little bit right here, but it's not really a big clinical picture where you have to look for many things and find many signs or anything like that. It's a very simple thing to diagnose, and it's a very obvious thing when the baby is just looking really big on the ultrasound. So the McRoberts maneuver, this right here, you can see leg elevation. That's all the McRoberts maneuver is. It's named obviously after, most likely after whoever came up with the maneuver. But this lifting of the leg is just a way to basically make the opening more wide, so that the big baby can come out with a little more ease. So flexing the hips against the abdomen, the leg positioning illustrated here can be used to assist in a delivery where the infant is at risk for shoulder dystocia. Right, so this is flexing. Flexing is always when these terms, flexing and extension and all that, should never be complicated after having done step one MSK. But sometimes it can be complicated to understand what it means to flex the hip, when flexing of the arms is something everyone knows. Everyone knows how flexing of the arms and stuff works, right? But flexing of the legs is basically the same exact thing. Anytime you're flexing your arms, you're basically bringing your fingers closer to your shoulder. So here, when you flex, you do this. You see your heel is coming closer to the butt, right? Which would basically be the shoulder equivalent of the legs. So this is what flexing is. While extending would be to make your legs completely straight, just like you make your arms completely straight when you're extending them. So flexing at the hips makes the opening bigger, lets the baby hopefully come out with a little more ease. A lot can go wrong here, as you can see from the pathological pictures I've added here, with the Herb Duchenne palsy and the Klumpke palsy, which are both Herb Duchenne and concave from back in step one musculoskeletal, they're both problems related to brachial plexus injury. As you can imagine, you have the brachial plexus right here and right here on both sides. When you're tugging this baby out, excessive stretching or bad forces that can be applied here could cause brachial plexus injury, which is usually pretty permanent. It's not going to recover. So you need to avoid all of that. They also wrote, what was the other thing here? Apply suprapubic pressure, which is what she's doing with the other arm right here. Right, applying pressure, pressuring in this aspect causes this aspect to come up. Right, so that's what our goal is. Our goal is to get this opening over here as wide as possible, so the baby can just easily come out. Wood's screw maneuver. This is when you enter the vagina and attempt a rotation, right? Hence the screw aspect. So you're supposed to try to get the baby in such an angle that it comes out more easily. This issue of shoulder dystocia gets further worsened when the baby is in a weird position. See, in this picture, the baby is in a pretty ideal position, right, where the head is presenting perfectly and you can just pull the baby out. It gets significantly worse if the head is on this side, which would be the opposite presentation, or if the baby is in a vertical way where basically the head would be coming out of the page and the legs would be going into the page. That positioning is even worse, because then there's no way that's coming out. And if it becomes really problematic, oftentimes the only thing you can go to is C-section. But before doing C-section, and that's going to be a very tricky answer choice to pick here, before doing C-section, one of the key things you can try is an episiotomy. Right, so we talked about episiotomies in step one as well. That was basically where you would cause an incision right here, cut it open so that the opening would become bigger, right? And that incision will obviously put the mother at risk for many things. She's gonna have urinary incontinence later on, and it's all kinds of issues that the mom will go through. But it all recovers. It all recovers. It's none of the well, hopefully none of the symptoms that an episiotomy will cause will be permanent. Now, what else can happen? So clavicular fractures may result in C8 to T1 brachial plexus injury that may cause Horner syndrome, Herb Duchenne palsy, or Klumpke palsy. These brachial plexus injuries usually resolve spontaneously, and if they don't, they become permanent. Right? So whether or not they resolve or become permanent often depends on how bad was the injury. Right? And again, nurses obviously do their best to make sure it's not that bad. Going back to the step one book real quick. We have upper extremity. So right here, right, brachial plexus lesions in first aid step one, we learned about all of these things. As we kept learning more, we got better at this, because in the beginning this was all obviously very, intense information, especially when we didn't really have really good understanding of the various nerves and how they travel and what they do. So all of these are things you need to memorize perfectly, not just for what we're looking at right now, but in general, you're going to get questions on all of these. None of this has gone away. The wing scapula, the thoracic outlet syndrome, none of this, even the distortions of hand thing, like these are all things I taught back in step one perfectly in ways that you would never forget them. Like this right here is a really good set of memorization techniques for perfectly understanding how to remember what kind of lesion each one of these things is. And then after I came up with those things, I never forgot them, and most students I taught it to never really forgot it either. So the first two things we see here, Herb palsy and Klumpke palsy, as you can see from the pictures I've added into the book, are things that can occur, obviously can occur to adults as well as to a newborn during the delivery process. As you can see, this must be a pretty big baby. During pulling the baby out, you're tugging the baby in a weird way, and that traction is going to cause brachial plexus injury. Same thing here, right? Pulling the baby in that manner where the arm came out first can of course cause traction injury, and all of these have very specific things that are related to it. So Herb palsy, you're supposed to think of the Herber trunk or the upper trunk, so that's the higher numbers up here, C5, C6. Traction over there leads to messing up the deltoid, infraspinatus, and biceps, right? So dibs. So Herb gets dibs on tips, and the tips part is supposed to remind you that you get this waiter's tip presentation, right? This apparently was how waiters would ask for their tip or take their tip way back in the day. What do you actually end up messing up? Well, if you don't have your deltoid, you can't raise your hand into the sky. So that's your abduction is messed up. Your infraspinatus is supposed to help with lateral rotation, can't do that. And then of course your biceps are not going to work, so you can't flex. Right, so you can see the arm is completely straight, which is extension. All right, so that's kind of what you end up getting. The biceps also help with supination, which is when your palm is facing up, asking for sup. So now you can't do supination, so the pronator works, and pronation is when your palm is facing down towards the floor. Right, so his palm is twisted the other way, so his palm is still pointing towards the sky, but only because his hand is towards the back. But this is pronation, because if he was to bring his hand up like this, bring his hand up to maybe grab something, the like if he brought his hand up like this, then his arrow pointing down would be pointing towards the floor, right? So this is pronation right here. These difficulties are very pronounced when you see it in the baby. You can see right here, same exact habit, right? The arm is completely straight. There's pronation here, and the baby's asking for its tip right there. All right, so elbow extended, forearm pronated, wrist and fingers are flexed, and there you have it. So this won't stop. The baby won't stop doing it. And of course, right after being born, you try to give the baby as much therapy as possible to fix that. And normally the baby's hand should be like this, not like this. Right, so that's a sign that you've already injured the upper trunk. The other one, clump K palsy, that's this one right here. With adults, it usually happens when they try to grab a branch as they're like falling or something. Right? They'll grab onto anything as they're falling from a height. So of course the grabbing thing ends up staying that way, right? And you get this claw hand. This is traction of the lower trunk, C8 to T1, the exact opposite. Right? So first we had C5, C6 for the upper trunk, C8, T1, the blue area, for the clump K palsy. This color-coded thing is perfect for learning purposes, and it really shows you where the problems are going to present. Right? So C8, T1, that's going to affect mainly your ulnar nerve. Right, so you can see median and ulnar nerves. So infants, you're going to have this upward force on arm during delivery. That's what's going to cause the issue, like this in the picture. And you basically mess up the intrinsic hand muscles, which is why you get this claw hand. Right, lumbricals normally flex MCP joints and extend DIP and PIP joints. But now you're getting this. So you can see that here as well. Right, it's supposed to be you can see the normal hand. It's supposed to just be like a closed fist, if anything. But now it's not a closed fist, right? The interphalangeal joints are flexed, right? That's why the fingers are moving outwards. And the metacarpophalangeal joints, MCP, they're extended, hyperextended. So that's all due to an injury in the lower trunk. You're gonna have those answer choices. Even here, you can see, this is an answer choice right here saying injury to a certain specific area, and you would have to understand what the problem was to even get that right. So let's take a look at these questions. First one here, 39-year-old, second pregnancy, 28 weeks gestation, right? 28 weeks gestation comes due to painful contractions for the past 4 hours, accompanied by the passage of clear fluid from her vagina. So she's getting contractions, but it's a little early. She initiated prenatal care a week ago, during which an anatomy ultrasound revealed a fetus with anencephaly. Her prior pregnancy was uncomplicated. She has no chronic medical conditions and has had no surgeries. Doesn't smoke or drink or use drugs. Vitals are looking alright. A sterile speculum exam reveals pooling of nitrozyme positive fluid in the vagina. We saw this in a question earlier too. There's another question we did where we saw this nitrozyme positive fluid in the vagina. The cervix is 4 centimeters dilated, 80% effaced. Bedside ultrasound reveals anhydramnios and an anencephalic fetus in the breech presentation. Fetal heart rate is normal. Tachometer shows contractions every 3 minutes. What's the next best step in her management? Well, looking at the way they're describing the question, right, everything looks like it's ready for delivery. Right, 4 centimeters dilated, 80% effaced, it's all open. The baby isn't distressed, so fetal heart rates are normal. Right, there's good contractions happening at a good rate, not too much contractions, not too few. So just allow spontaneous vaginal delivery. There's absolutely no contraindication in this question whatsoever that says you should not allow spontaneous vaginal delivery. So 20% of people chose perform cesarean delivery, but there's really no reason to. Her cervix is opening up just fine, right? And the baby isn't distressed. So everything should work out just fine. Plus, on top of that, it doesn't really look like the baby's gonna make it per se. You really don't want to do a C-section for a mom whose baby is just gonna die. Like that's like getting a C-section for absolutely no reason. So just allow spontaneous delivery. Anencephaly is a lethal fetal anomaly characterized by failure of neural tube closure, which results in the absence of the cerebrum, thalamus, hypothalamus, and portions of the brainstem. So this baby, although the fetal heart rate is normal, the baby is not going to develop. Right? The baby is not going to develop. She is a this is her second pregnancy, but for some reason, she's had no responsibility in the second pregnancy, right? Because you could tell she initiated prenatal care just a week ago. That kind of a sentence is a big deal for you. As a doctor, you'd be very upset with her because she's been pregnant for 28 weeks, but she just came on week number 27 for prenatal care. Like at that point, you might as well not even come anymore. Go do it in your quote unquote natural way and then just deliver the dead baby yourself because, what are you doing with your life? I mean, she must have learned something from her first pregnancy because clearly the first pregnancy succeeded, right? It's P1, not A1. So I'm not sure why she didn't come earlier for the second pregnancy, but you're supposed to read that kind of a sentence and feel some sort of way against her, right? That would tell you, as you read the rest of the question with the anencephaly, that the baby's not going to make it. And then you would think, okay, since the baby's not going to make it, I'm not going to force the mom through something she doesn't need to go through, which is a C-section. Right? So the principle behind labor management of patients with lethal fetal anomalies is to minimize maternal issues, any maternal issues. Thus, obstetric care for them is maternally focused. Vaginal delivery has a lower risk for maternal complications compared to cesarean delivery. Plus, remember that everything about history of prior things that happen in prior pregnancies matters, because if it happened in a prior pregnancy, it'll happen in the next one too. So if you do a C-section for her right now, if she gets a third pregnancy, and hopefully she'll be more responsible that time around, then she'll most likely need a C-section in that third one as well. So you don't want to do that. Right? So this is the, I guess, almost remotely ethical thinking you would need to not perform cesarean delivery. There's no reason for it. You're going to be doing cesarean delivery for basically a dead baby. That's unnecessary. Right? So that's kind of what you have to do. There's also no fetal monitoring, so do not pick any as choice where maybe they'll say, oh, do a contraction stress test or something like that. No, you don't need to do anything for a baby once you realize that the baby has anencephaly. It basically doesn't have a forehead. It doesn't have a brain. So you don't need to do anything for that baby. Just, get it out and make sure the mom is okay. Prevent DIC in the mom. Don't forget anything inside, stuff like that. It's a very straightforward question just to teach you a very specific thing, that if you have any of these fetal diagnoses, you don't do anything for that baby. The baby is basically a non-viable fetus. It's practically already dead. Although the fetal heart rate is working, it's only working because the mom is supporting it. That's it. Then we have the shoulder dystocia stuff. So of course this UWorld table teaches a lot more than the book over here does. It breaks it down a lot better. And then we have this question, so let's take a look at it. 1-day-old boy is evaluated in the nursery for minimal right hand movement. He was born at 39 weeks gestation by forceps assisted vaginal delivery to a mom with insulin controlled gestational diabetes and obesity. The delivery was complicated by shoulder dystocia. So they tell it to you in the question. Birth weight was really high. Exam of the right upper extremity shows extension of the wrist, hyperextension of the metacarpophalangeal joints, and flexion of the interphalangeal joints. So that's basically an explanation of the claw hand, right? Because they're talking about joints of the fingers. So if you're moving around joints of the fingers, you must be talking about making the claw hand. Grasp reflex is absent in that hand only. Moro and biceps reflexes are intact. There's no crepitus. The left arm is normal. See, so that's what they're literally describing what this picture is. Left hand is normal, right hand looks like that. There is slight ptosis of the right eyelid, and the right pupil is 2.5 millimeters smaller than the left. So now that describing Horner syndrome, right? Horner has PAM. So the P for ptosis, the A for anhidrosis, and the M for meiosis. Meiosis is constriction of the eye, which we see. Anhidrosis is not always seen. Even if the person has anhidrosis, it's not something you can always catch. But the ptosis and meiosis are good enough for you to figure out that this must be Horner syndrome. The remainder of the exam is unremarkable. What is the most likely cause of this presentation? Well, it must be injury to the 8th cervical and 1st thoracic nerves. While 25% of people chose injury to the 5th and 6th cervical nerves, but 5 and 6 are the upper part of the brachial plexus, right? C5, C6. Upper trunk, which is for herb palsy, so that was completely off. But this question was actually double easy because they gave you both things. They gave you the Klumpke palsy in the question, and they gave you the Horner syndrome. They didn't need to give you both things, but UWorld does that. UWorld makes big, thick questions with everything in it, so they could teach you all the things that occur together. So for teaching purposes, they've given both things. But in all reality, they could just give you that the baby was born a day ago and the baby now has Horner syndrome on the right side. What else would you expect to see? You would expect to see right arm looking like this. What would you find? You would find injury to C8, T1, and the lower trunk of the brachial plexus. The infant has Klumpke palsy, a brachial plexus injury caused by shoulder dystocia. Excessive traction of C8 to T1 during a delivery can result in the rare complication of hand paralysis with the claw hand deformity and associated damage to the sympathetic fibers of C8 to T1, manifesting as ipsilateral meiosis and ptosis. Right? So you lose the sympathetic fibers, which is why the parasympathetic fibers are now winning. The parasympathetic fibers cause meiosis, right? Parasympathetic fibers cause your pupils to basically close, which is like going to sleep. Parasympathetic is the rest and digesting. When your pupils are dilated, that's a sympathetic thing. Duchenne palsy is the most common type of brachial palsy, which is the other answer choice, and that involves C5 and C6 nerves leading to a waiter's tip posture, right? But that would look like that. So that's kind of how you're gonna get tested on these things. So that takes care of these two topics, but there's also 3 other topics that can be tested based off of shoulder dystocia. You can get a question on any one of these. The question we just did right now was regarding these two things, where the actual issue was this kid had Klumpke palsy. You could get a fractured clavicle, right? So the intact biceps and grasp reflexes. Remember that always think of things that are not in the question to figure out what the answer is, right? For example, if your question is about a fractured clavicle, then they probably won't be putting this in the question or this in the question, right? None of these things will happen. So you can already cancel out 2 answer choices and start thinking that the issue must be with some kind of bone up here, and don't fall for the answer choice of doing an x-ray. Infants are too young to do an x-ray, right? You're gonna cause radiographic damage to their immature bones, right? Because it's not even fully bones yet. A lot of it is still cartilage. So you don't want to do, never want to do x-rays. So fractures, naturally, as med students, oftentimes we'll think of fractures and order an x-ray, but that's for adults, not newborns. So the first thing that you can notice in a baby is this crepitus thing. Right? You can see it right here, and I think I have questions somewhere where we see this too. Right? So when you have a fractured clavicle over here or fractured humerus somewhere here, then at those points what you do is you just palpate the baby, and you're going to hear this crackling sound of practically like popping air bubbles, and that's when you know. And of course there's going to be some bony irregularity, and the baby is going to be crying nonstop. There's also a decreased motor reflex on both of these fractures due to the pain. So the baby's going to be crying non-stop, inconsolably, which is something they'll focus on a lot in the question. And the rest of it is just going to be based off of whatever else they tell you in the question, because they present very similarly. As you can see, the 2 boxes say the same thing. There's nothing different in the 2 boxes up here. They present the same exact way. So which one it is will really depend on whatever else they tell you in the question stem. The last thing is perinatal asphyxia. This has variable presentation depending on the duration of hypoxia. Right? You're going to have a baby with automental status, respiratory or feeding difficulties, poor tone, and seizures. Right? Perinatal asphyxia. Let me just see if I can find a quick picture for this. The asphyxia thing basically is just related to not getting enough oxygen, but there's no real picture for this necessarily. Okay, I mean this kind of this is nice. This image I'm gonna post right here kind of does the breakdown of what you're seeing pathophysiologically. So phase 1, again, asphyxia is just a hypoxia thing. So phase 1 is hypoxia. You get prolonged hypoxia. You get halt in electron flow of the respiratory chain. You're not going to be able to make ATP because there's no electron transfer system at that point, which is a biochem thing. depletion of ATP stores, and then accumulation of calcium in the mitochondrial matrix, accumulation of sodium in the cytoplasm, and accumulation of potassium in the extracellular environment. All of which are happening because you stopped your ATP dependent pumps, right? The sodium potassium pumps. So you're supposed to pump sodium uh, out and pump potassium in, but you're not going to be able to. That's why sodium is staying inside the cytoplasm, potassium is staying outside in the extracellular environment, and you get cell death. So to fix all of this, you do reoxygenation. But then even that is often dangerous because when you do reoxygenation, one of the key things we've always learned about is creating excessive reactive oxygen species, which then causes oxidative damage anyway. Right? So no matter what, with asphyxia, it's always going to be a problem, and you have to do the reoxygenation. There's no other option, but long-term problems will present. Right? So perinatal asphyxia is going to be very different from these other four topics because the key thing in asphyxia is hypoxia. The baby wasn't getting enough oxygen, which was probably, if the baby was being monitored, then you would probably see that with decelerations with every contraction. It could have been due to many reasons that the baby became hypoxic, and you'll have to figure that out based off of whatever they tell you of how the baby was being monitored. Next thing here, failure to progress. Right, so this is associated with chorioamnionitis, occiput posterior position, nulliparity, and elevated birth weight. So occiput posterior position is the one I was just talking about earlier, where the head, instead of being in the front, the head is in the back. So the legs are over here. That is really dangerous because then this picture is showing you how you ideally want the baby to be, all folded up nice like this, but the baby isn't always all folded up nicely like this. So getting the head out, as you can see, is much wider. Sorry, getting the legs out is much wider than getting the head out. Right? So if you get the legs out first, you can imagine that as you pull the baby out, imagine, just reverse this picture. So now as you pull the whole baby out, if the baby has mostly been pulled out and then the head is right here, the cervix is just going to close in on the neck of the baby, which really sucks, right? That is really dangerous, right? So if you just imagine reversing this so that the head is over here now and the baby has already been pulled out, the rest of the baby is already pulled out, right? And then of course the cervix closes at the neck because the whole time the cervix was rubbing against all of this portion, and then it just shut, and that's gonna suck. It's also gonna close with a lot of force, which can possibly even kill the baby. And you have to remember that the mom is in a lot of distress right now. She's putting in a lot of force and pressure and whatnot, and there's a lot of muscle contractions happening in this area. Right? So not exactly the best case scenario for the baby. Not the best case scenario. So definitely something to watch out for in questions when they tell you how the baby is positioned inside the mom. Maybe from an ultrasound they did, but most times it's going to be due to the infection inside the amnion. So first stage protraction or arrest, or prolonged second stage arrest. We've seen already earlier when we were looking at questions with these kinds of graphs what these things look like. So in the first stage protraction or arrest, labor that fails to produce adequate rates of progressive cervical changes. Right, we saw this way in the beginning when we first looked at. Let's see, I think it was somewhere. Right, yeah, way in the beginning. So it was one of the first few things we saw, which is this graph, right? Where is it? Oh, right here. Okay, so this thing, right? So when we looked at this graph, this is showing you, let me bring it over there so we can continue looking at it. So they're saying labor that fails to produce adequate rates of progressive cervical change, right? We saw that there was supposed to be a cervical change of at least 1 centimeter every 2 hours, right? There's no cervical change here for 4 hours. Yep, for time number 4 to time number 8, cervix is staying at 8 centimeters. That's bad, right? We saw what the normal one was supposed to look like too on that same page, and that's what you need. So when you have a lack of cervical change, that is arrest in labor arrest. Prolonged second stage arrest is arrest of fetal descent, most commonly caused by fetal malposition. Right, so that's going to be the occiput posterior positioning or the or the the vertical positioning where the baby is just sideways and you can't get that baby out. You have to turn the baby around. So what do? Well, treatment, they have this table here, right? So failure to progress, how do you treat this? Well, if they have it broken down into first and second stage. If it's in the first stage where the cervical change is not occurring and the mom's cervix is not dilating anymore, then you need to figure out the treatment based off of what's happening. If it's her first pregnancy, right, then more than 20 hours of no cervical change is defining as failure to progress. If it's her second pregnancy, then, or anything after the first, then more than 14 hours. But the point is, you won't even really need to worry about this. If it's a long period of time, there's no cervical change, she has latent um, latent stage arrest. So you do therapeutic rest via parenteral analgesia, oxytocin, amniotomy, and cervical ripening. You try to get things in a position where she calms down and relaxes, and the cervix eventually starts opening up. Right. So amniotomy is one of the key things here that this answer choice is always going to be there, but you don't really want to pick it because amniotomy is kind of dangerous for the baby. Now, if it's in the active stage, if there's an active stage that has an arrest, dilation of at least 6 centimeters and either no change in dilation with 4 hours of adequate contractions or no change in dilation with 6 hours of inadequate contractions, then those are considered also failure to progress. Also related to the same table we were looking at, the same graph I had just taken from that previous page. So then again, now the amniotomy becomes much more significant. You have to do this. You could still give oxytocin to stop contractions or anything, but C-section if the previous interventions are ineffective. But amniotomy should do the job. Here you would do it. In the first area, you try to do other things besides amniotomy to get the cervical ripening to occur, and hopefully the cervix starts opening up, right? So that's something that often will be a problem. Then you have fetal descent, which is related to this picture right here. Right, so let's say the cervix has opened up fine and the contractions are okay and everything's going well. So now you get to see the numbers and what they meant in terms of fetal descent. Right, so the more negative number means the baby's still inside, the more positive number means the baby's coming out. That's kind of what we talked about earlier as well when we looked at the same graph, this graph right here. Right, so you see you have station of fetal head goes from -2 to +3. Right, that's these numbers right here. So of course, as delivery is correctly occurring, oh, let me go get the normal graph too from that page. Around 386. Okay. I have no idea where that shit is. Okay, they left the termination. So if we look at the normal graph also, in the normal graph, you can see that there is more than 1 centimeter of change every 2 hours in the cervix of the mom, right? Every 2 hours is going up by 1. Another 2 hours goes up by 1. Right, so that's normal progression. And the baby started at -2. The baby's all the way inside, right? -2. And then as the cervix is opening up, the baby is coming out. Right? The baby is now in the +1 area, which means the baby's head is now outside the cervix. And now you can start getting the baby to come out of the mom. Right? Take the baby out of the womb. So this graph is showing you normal. This is already pathological to begin with because you can see that the baby's starting at 0, which means the baby's kind of like right there already, and you can see everything. But if the baby's already at 0, the cervix better be open, and the cervix is not that open. Right? You can see the cervix is still pretty closed, only at 5 centimeters, and then the cervix stops opening. So how do you get the baby out? The baby's stuck at -2. Right, so I mean at +2 inside. The baby's still stuck inside +2. So this is all really, stuck outside. Excuse me, stuck outside. Plus numbers are outside. So the baby's come out to like right here, +2, right? But the baby's now stuck at +2 because the mom's cervix isn't opening up anymore. So from that much, all that probably came out is like the head and up to the neck maybe, or the cheeks. But then how are you gonna get the rest of the baby out, which is bigger than the head? Right? The head is perfect for coming out because it's nice and smooth and circular, so it just comes out without anything to get stuck. But once you get to this point, the shoulders are things that can get stuck if the cervix is not open enough. And here you can see the cervix is no longer opening up anymore, so the baby's going to stay stuck at +2. The rest of the baby is not going to come out. right? So all kinds of things that can occur. Now this image here was an active phase arrest. So let me talk about that, the active versus latent phase arrest. So we can move this, let me just keep it right here for now, just because it's relevant. And I think we could fit this right here too. There you go. So in active phase arrest, that's this second story right here, right? Where you would be looking at this along with the contractions and other graph, the graph that looks like this, right? The fetal heart rate with contractions. You would look at both together. And we actually did a question earlier that had both things together. It was a very easy question, but it was supposed to be intimidating for those who didn't really prepare this very well. So in the active phase arrest, you can see that the difference between active versus latent is the blue and the pink. And the blue and the pink part is active phase, right? And then the blue part is latent phase. So active phase arrest means that enough dilation has occurred so that you're above 6, which is why they're saying at least 6 centimeters, right? So you can see the numbers of the dilation are on the left side. And once you dilate at 6 centimeters, now you're in active phase. From 6 to 10, the whole part is active, because if you've opened up 6 centimeters, the baby's coming out now. So it's no longer a latent thing, right? It's not a passive thing anymore. Something actively is occurring. And in the active phase, there's an arrest. There's no more dilation occurring. So this image right here shows you active phase arrest, right? Whereas latent phase arrest would be further down here, where maybe something like this would happen. Like you would get this line and then it would just stop. No more dilation occurring, right? So that's the latent phase arrest. At this point, it's not really that bad right now. You need to do cervical ripening, give her analgesia, and hope that the contractions and extension of opening starts occurring, so that it goes like this all of a sudden and the cervix opens up. But if it doesn't, then that's going to be a problem later on. So we'll see that if we find a question that has that. But yeah, that's what they're talking about here. Now, second stage, this is arrest of fetal descent, right? So the baby's head coming out part. So that's what we're looking at now. So arrest of ascent. Now, for the primigravida, right, you have to give her more time. That's all that matters. With the primigravida, first time pregnancy just means you give them more time. That's all they're talking about here. So don't get too worried about the timing aspect. But what do you do when there's a second stage arrest of fetal descent? So that means that normal labor progression occurred, and then the fetal descent has paused. So instead of, you see how in this question, active phase arrest, this was the problem, the solid line was the problem. With the second stage arresting, the dashed line will be the problem. So you might get something like that's occurring like that, and then it just stops descending. The head stops descending. The baby stops coming out. So then what do? Well, observe, right? Continue oxytocin and assist with forceps or vacuum, and that's usually the number one thing we do now, right? Not the C-section. You use the forceps assisted delivery or the vacuum assisted delivery, which of course is related to a very specific question that you also get, so something called the hematocolpos. It's a very interesting thing that occurs where there's going to be a little bit of a hematoma over here. So don't think of it as any kind of really malignant issue. It's not a very malignant issue. Sometimes when you do forceps assisted delivery or vacuum assisted delivery, you cause a little bit of scalp injury, which causes blood to build up under the scalp. We'll see questions on that pretty soon. That's not a really big issue. You don't really need to do anything either. It'll resolve by itself soon enough, right? But that's all that's about. So let's take a look at this question over here. So you have a 36-year-old woman, first pregnancy, right? 38 weeks gestation, so she's ready to deliver soon. Comes in due to increased leakage of fluid, so rupture of membranes must be occurring. She reports spontaneous rupture of membranes about 48 hours earlier, and contractions started 12 hours after rupture. She reports intermittent vaginal spotting and regular fetal movement, so that's good. The fetal movement part is good. She was attempting a home birth, but came to the hospital because her cervix has been 6 centimeters dilated for the last 5 hours. So you know that once it hits 6 centimeters, that is an active phase, and for the past 5 hours, it's staying at 6 centimeters, so that's an active phase arrest. Temperature is high for some reason. Blood pressure is fine, pulse is fine. Digital exam reveals cervix to be 6 centimeters dilated and 70% effaced, with the fetal vertex at 0 station. So the fetal vertex is basically just ready to come out. right? Just ready to just basically come out. Fetal heart rate tracing is shown below. What is the most likely responsible for her fetal monitor findings? So, what do we see? Well, you're supposed to compare where the contractions and accelerations are occurring. So there's a contraction here, and then there's an acceleration there, and it doesn't look like the accelerations are related to the contractions. Not really, because then you have this one here where it occurred before the contraction, right? So the contractions are looking fine. The mom's contractions are perfectly fine, but something's weird up here. So remember what was normal heart rate, right? Normal heart rate, did they give a number here in the question? They didn't give fetal heart rate number, but normal heart rate was supposed to be from 110 to maybe like 160. This baby is at maximum heart rate and it goes above that. So that's fetal tachycardia. The question didn't have this labeled. It wasn't labeled in the question. Right? This is just an explanation graph that I put here. Obviously, when they gave me the question, nothing was labeled. But you could tell that normal is from 1 here to like 160, which is right here. So this is above that. So the baby has a high heart rate. And on top of that, there's accelerations that are occurring, which is a sign that the baby is distressed. But contractions are occurring normally. There's nothing wrong with the contractions. So if you're having accelerations and tachycardia and the mom has a fever, the best answer choice to pick is any answer choice with an infection, intraamniotic infection. Why would you pick intraamniotic infection? Because that is the one kind of infection that would present like this and cause active phase arrest, which is what this question is about, failure to progress, right? Her fetal heart rate tracing has moderate variability, which is good, and fetal tachycardia, which is not good, a sustained fetal heart rate of more than 160. Common causes include maternal infection, poorly controlled hypothyroid, medication use, and abruptio placentae, among many other things. There's a lot of things that can cause the baby's heart rate to go up because the baby's basically panicking or not feeling good. She has an intraamniotic infection of the uterine decidua, placenta, amniotic fluid, membranes, and umbilical cord that results from migration of vaginal or enteric flora through the cervix into the uterine cavity, which is basically what's going to occur if you try to do a home delivery. In the setting of protracted or arrested labor and prolonged rupture of membranes, maternal fever suggests intraamniotic infection as the etiology of the fetal tachycardia, right? Because look at that. They told you in the question, her rupture of membranes occurred 48 hours. That's 2 days ago. That's 2 days of time that the ruptured membranes were prone to infection. And she came today because that's just what she decided to do, right? And contractions and whatnot, everything's been occurring for 2 days. She should have been here the moment she couldn't figure it out the same day, right? But she didn't come in. Additional clinical features include maternal leukocytosis, purulent amniotic fluid, maternal tachycardia, and uterine fundal tenderness, all of which are other things you can see in the patient. Broad spectrum antibiotics are administered to reduce the risk of neonatal and maternal morbidity. And the baby should be fine, but delivery needs to occur, and thankfully she's on time for delivery, so you just get the baby out, right? The baby should be fine, but the last thing you want to do as a baby is start taking antibiotics the day you're born. Alright, so that's something to keep in mind too. But if it's necessary, it's necessary. And here, unfortunately, it will be necessary because the mom didn't do a good job. Right? So that's active phase arrest. So always remember, active and latent, the differential is 6 centimeters. Once you've hit 6 centimeters dilation, if you stop after that, like you stop here after 6 centimeters, that is active phase arrest. That's not good. Right? So that's all that's about. Here comes the next thing of rupture of membranes, which is what we just talked about. Rupture of membranes can occur for many reasons. The normal one is spontaneous, which occurs after or at the onset of labor, when it's time to deliver. Premature rupture of membranes, often written as just PROM, P-R-O-M, occurs more than 1 hour before onset of labor. So it's not always going to be just an hour before. It's going to be like, it basically occurs within the 24-hour period before onset of labor. May be precipitated by vaginal or cervical infections, abnormal membrane physiology, or cervical incompetence. Very common for premature rupture of membranes to occur. Very common. It just means that the mom was almost ready to deliver. Labor was supposed to start now, and then the rupture of membranes occurred a little early. That's it. Now, this is not normal. Preterm premature rupture of membranes. So preterm, now it's just early. Too early. Right? Rupture of membranes occurring less than 37 weeks gestation. So that's kind of like preterm is kind of like premature, but there's a confusion of wordings here. So premature rupture of membranes means that it occurred a little earlier, but it was still on time for delivery of the baby. The baby's ready to come out, but the rupture of membranes occurred a little too early. Preterm prom is more of a premature baby, right? Here, the rupture of membrane was premature, but in preterm prom, the baby is premature, right? Less than 37 weeks. So this might happen in like 35 weeks. That's a premature baby still, right? So preterm prom is the problematic one. These two are not that bad. These two don't mean anything. In movies, what we often see is premature rupture of membranes, where the mom is just at home and then boom, her water leaks, and then the husband has to get her into a car real quick, and they're driving through crazy traffic, being chased by cops, all of those things. That's kind of what we see in movies a lot. That's normal stuff that occurs, not the being chased by cops part, but the rupture of membranes occurring a little bit before it's actually ready time to deliver the baby. Very normal, common thing to occur. This is also common, but not a good thing. This is bad, right? And then prolonged rupture of membranes. Rupture of membranes occurring more than 18 hours before delivery. That's what we just saw with the mother in our previous question. That's also really bad. Risk factors include low socioeconomic status, young maternal age, smoking, and STDs, right? So you're going to have to do a good job differentiating between all of these and what they're all supposed to mean, right? Because there is a very solid definition here, but again, like which one is actually occurring will really be based off of what the mom is going through, how long it's been going on for, what the mom's pregnancy gestation age is, stuff like that. We're going to see that in this question here. So patients often report a gush of clear or blood tinged amniotic fluid. Uterine contractions may be present. Diagnosis: sterile speculum exam reveals pooling of amniotic fluid in the vaginal vault. This rupture of membrane is what creates this nitrozyme positive amniotic fluid. So every time they ever mention there's nitrozyme positive fluid, it's amniotic fluid. So membrane rupture has occurred, right? Positive Fern test. A ferning pattern is seen under a microscope after amniotic fluid dries on a glass slide. Right, so the positive Fern test is just they're seeing amniotic fluid. Right, so both of these, the nitrozyme and the Fern test, if they ever mention that in a question, and we saw a question about this, then that means they're talking about rupture of membranes. The question we saw about this was about I believe, an ectopic pregnancy, a bad pregnancy or something weird. I can't remember exactly what that question was, but we did it like 2 or 3 videos ago where they mentioned a positive ferning and nitrozyme pooling and all that, and that was to indicate that amniotic fluid has been leaking now and rupture of membrane is done. And either it was an ectopic pregnancy, or I think it was some kind of pregnancy that wasn't going to work out too well because the baby was definitely going to die. So something weird was happening there, and the goal in that question was to just get everything out. Right, so these things are indicators that they're going to use in questions to catch you off guard. If you haven't studied it, you'll never know what they're talking about. Ultrasonography is what you're going to do, as usual, to assess amniotic fluid volume. If diagnosis is uncertain, ultrasonography guided transabdominal installation of indigo carmine dye can be used to check for leakage. Right, so this is the ultimate thing to do to see if there's leakage or what's happening. Right, so you just put transabdominal indigo carmine dye, and then if you put the dye in and the dye leaks out, then you know there's leakage. If you put the dye in and no dye comes out, then there's no leakage. So then you need to figure out where this amniotic fluid is coming from. Minimize infection risk. Do not perform digital vaginal exams on women who are not in labor or for whom labor is not planned immediately. Right? Because as soon as you do digital vaginal exams, you risk bringing in all kinds of bacteria. Check fetal heart tracing, maternal temperature, white blood cell count, and uterine tenderness for evidence of chorioamnitis, which was our previous patient that we just did. Treatment depends on the gestational age and the fetal lung maturity. Right, earlier in one of our questions, we saw the list of things you're supposed to give to make sure that the fetus is growing correctly before you deliver. Right, so here we're going to see the lung. For the lung, we gave corticosteroids, right, betamethasone and dexamethasone, to promote fetal lung maturity. There was also the other 2 things I can't think right now that we need to give to the baby so that the brain matures correctly. That was the magnesium. And then whatever the third one was, it's not coming to my mind. But yeah, those are the things you need to get to make sure that the baby is growing correctly, just enough, as much as possible, before delivery. So here they only talk about the lung part because you're hoping that you've already made it to 34 weeks at least, right? Um, because this is rupture of membranes. So term, first check GBS status. Of course, you need to give penicillin if there's any possibility of strep Ehrlichia infection during delivery. Labor may be induced or the patient can be observed for 6 hours. 34 to 36 weeks gestation, labor can be induced and just get the baby out. If it's less than 32 weeks, then you need to kind of prevent delivery. You know, let it grow more. Right? So expected management with bed rest and pelvic rest. Don't try to deliver under 32 weeks gestation, right? And then corticosteroids, of course, to help fetal lung maturity. If signs of infection or fetal distress develop, give the antibiotics and induce labor. This is why you don't do the digital vaginal exam, because you don't want infection. If you cause infection, you have to induce labor. Preterm labor and delivery, chorioamnitis, placental abruption, and cord prolapse are some of the bad things that can yield from such a scenario. And that would be pretty unfortunate. So let's take a look at these two questions here to see what's happening with these guys, these women. 27-year-old, second pregnancy, 10 weeks gestation. Okay, comes to the office for an initial prenatal visit. So 10 weeks in, she's coming for her first visit. Not the best, but okay. She has no cramping or vaginal bleeding. She was not expecting this pregnancy because she had an uncomplicated term vaginal delivery 6 months ago and breastfed for the first 4 months postpartum. Oh, okay, so it's a surprise pregnancy. All right. That's actually pretty problematic, right? Because if you got pregnant and you weren't expecting it, then you probably weren't preparing for it with folate either. She is taking a daily prenatal vitamin now, but it's already been 10 weeks. I don't know how long she's been taking it for. And has no chronic medical conditions. Vitals are looking fine. Abdomen is soft, not tender, non distended. Pelvic ultrasound reveals a singleton intrauterine pregnancy at 10 weeks gestation, which is fine, with a fetal heart rate of 165, so that's a little high. Hemoglobin is 10.4. She's at increased risk of what pregnancy-related complication? Well, looking at the fact that she was not expecting this pregnancy and the baby's heart rate is kind of tachycardic and her hemoglobin is low, right? This is anemia. Then what would you pick? So the correct answer here was preterm, pre-labor rupture of membranes, PPROM, which is the bad one, right? You would not pick one of the good ones. Why would you pick one of the good things? She's not doing too well. Something is not okay here. So what's actually happening with her? Well, pregnancy, delivery, and the postpartum period place increased physical and metabolic demands on women in order to develop and provide nutrition for the fetus and newborn. During pregnancy, maternal folate and iron are depleted for fetal development. The baby takes it all. And the resulting maternal anemia is exacerbated by normal blood loss during delivery. In breastfeeding women, continued nutritional demands from the newborn prevent repletion of the normal folate and iron stores, resulting in prolonged anemia as seen in her. Right, what she talked about, she was for 4 months she's been breastfeeding. So even after delivering 6 months ago, she's kind of not really had a chance to replenish everything she used up in making and feeding that first baby. And then she started making the second baby unexpectedly, and she must have been at a lack of resources for her body to correctly prepare making the baby. So if your body's not ready, you're going to have preterm rupture of membranes. Right? Preterm premature rupture of membranes. And that's all this question is about. Due to these increased demands, women with short interpregnancy intervals have an increased risk of pregnancy complications, including low birth weight, preterm labor, and preterm pre-labor rupture of membranes, any of which could have been possibly the correct answer choice. Thus, appropriate pregnancy timing with interval contraception is recommended for adequate maternal recovery and optimization for future pregnancies. Right, so this one was a short interpregnancy interval, which is why she was at risk of a couple things, because her body's not ready to get pregnant again. That's all this was. And then management of preterm pre-labor the workflow. So this is basically talking about the treatment aspect, right, which was all of this. Really just depends on how much time the baby has had to get ready, right? So here they listed out both things, corticosteroids and magnesium. So first things, 34 weeks. Is it less than 34 weeks or is it past 34 weeks? If it's past 34 weeks, the baby is mostly done being made and ready for life. Just give it some corticosteroids for a little bit of fetal lung maturity and that's it. So past 34 weeks, you can see that they gave corticosteroids. They did the GBS prophylaxis, which is what you always have to do for every single delivery. So it's nothing unique here. and just get the baby out. That's it. But if it's not 34 weeks, if it's still too premature of a baby, which is why this is preterm, because it's a premature baby, then if it's less than that, what do you have to do? Well, thankfully, most case scenarios will be uncomplicated. There's not going to be an infection or some kind of maternal compromise or any of these things. If there is some kind of complication, then you just have to do delivery. You can't do anything. Just got to do the delivery. Do the delivery and set it up as much as you can before the delivery with corticosteroids for the lungs, magnesium for the brain. Any intraamniotic infection, you try treating it the best you can with antibiotics for both the mom and the baby. But if it's uncomplicated, and that's usually what actually occurs in real life, but won't occur in STEP. If it's uncomplicated, then you just do expected management, give the baby things to make the baby mature, and just watch until the baby's ready to be born. Just surveillance. Surveillance ends up being the key answer choice there. So you're going to be picking answers. These are the answers you're going to have to pick. If it's uncomplicated, just watch. If it's complicated, there's some kind of issue, then do whatever you need to do to resolve the issue and do delivery. Right? Delivery is the key thing there. Best next step. So, for example, let's take a look at this question. 40-year-old. So now you already know from the beginning, as soon as you see the G3P2 after that this is too old of a woman to get pregnant, as far as STEP is concerned. In the real world, not so much, but on STEP, yes. This is her third pregnancy, and she's at 33 weeks gestation. Comes to the labor and delivery due to leakage of fluid. She has had intermittent leakage of clear vaginal fluid for the past few hours, but no vaginal bleeding. She has had some irregular contractions for the past few weeks, okay, but they are non-painful. So vaginal fluid means rupture of membranes has occurred, and she's getting contractions, so she's getting ready to deliver. Irregular contractions. Fetal movement is normal, that's good. She has diabetes and polyhydramnios on her most recent fetal ultrasound. Oh, so that's also a problem, right? So diabetes and polyhydramnios, too much amniotic fluid. Too much amniotic fluid is always an issue, because then you wonder why it's accumulating. Is the baby unable to swallow it? Anencephaly, the GIT disease, stuff like that. Temperature, blood pressure, pulse, and those are fine. BMI is not good. She's overweight, significantly overweight. Fetal heart rate tracing shows a baseline of 140, which is good. Moderate variability, multiple accelerations. The multiple accelerations is not good, because that means the baby is distressed by something. Tocodynamometer reveals contractions every 15 to 18 minutes. The uterus is non-tender. Speculum exam shows a closed cervix and clear fluid in the posterior fornix of the vagina. There is ferning. So you see the ferning test is positive, which means that amniotic fluid has come out. A transabdominal ultrasound reveals a fetus in the vertex presentation, surrounded by minimal amniotic fluid. The deepest vertical pocket is only 1 centimeter. So this is a bad biophysical profile. What is the best next step in her management? So here, in this case scenario, because it's under 34 weeks, right? Under 34 weeks, you will not be doing this. So now you're between, is it complicated or not? Well, this is clearly complicated, right? There's some issues occurring, but it's not one of these complications. It's not an infection. It's not maternal compromise. None of that things, right? Whatever's happening here is not one of these issues, right? So then this still qualifies as a quote-unquote uncomplicated issue, because see, what you're seeing are all normal things, right? The fetal heart rate is normal, the mom's vitals are normal, the contractions are occurring, there's moderate variability, which is normal, the cervix is still closed, which is telling you it's not time to deliver yet, and that makes sense because it's under 34 weeks. So all in all, this ends up also just being uncomplicated. And this is uncomplicated. Nothing major is wrong yet. The baby's not about to die. The mom's not about to die. Everything's okay. So next best step, you would pick any one of these answer choices. Prophylactic latency antibiotics. That's it. Latency antibiotics. While 25% of people chose amnio infusion, which, why do you do amnio infusion? Well, you do amnio infusion whenever there's not enough amniotic fluid. And her amniotic fluid is very low. So we'll see why that's wrong. And then 15% have chosen amphetamine taucolysis, which would stop the contractions. And that you do when there's contractions that you don't want, because it's too early. So both of these other two answer choices are respectable wrong answer choices. Like, I have nothing against the students that chose it because it makes sense to come to that idea. But the question at hand is about the next best step in her management. What would you do about her delivery? See, the other two answer choices are not necessarily just about her, it's also for the baby per se. But right now, we just need to figure out what are we going to do with her in terms of her current presentation, which is leakage of fluid. Whatever we're going to do with her is just basically going to involve prolonging the time. It's been 33 weeks. We needed to get to 34 weeks, hopefully 35 weeks, and then deliver. That's the answer you needed to pick. For vaginal pooling of nitrosamine positive alkaline amniotic fluid with burning on microscopy is consistent with PPROM, where she has rupture of membranes and there's leakage of amniotic fluid. Rupture of membranes at less than 37 weeks gestation prior to the onset of labor. Risk factors include prior PPROM, as well as conditions that overdistend and weaken the membranes, making them prone to rupture, such as her polyhydramnios. Other things are GU infection or antepartum bleeding. Management depends on the gestational age and the mom fetal status. Benefits of further fetal development in utero are balanced against risks for maternal complications. In the absence of complications, patients with PPROM at less than 34 weeks gestation require inpatient expectant management with prophylactic latency antibiotics to prevent fulminant intraamniotic infection, corticosteroids like betamethasone to decrease lung immaturity, and fetal surveillance, non-stress tests, growth ultrasounds, etc. Patients with PPROM are typically delivered at 34 weeks gestation, but if complication develops earlier, then delivery must be done. Amnioinfusion treats variable fetal heart rate decelerations in labor, but is not indicated in PPROM for oligohydramnios treatment. Tocolysis temporarily halts contractions to delay delivery, but is contraindicated in PPROM because contractions often indicate a complication that requires delivery or intervention. So what's happening with the other two answer choices? Well, you didn't need to do amnioinfusion because why would you actually do amnioinfusion? As I said, you do amnioinfusion when there's not enough amniotic fluid. When there's truly not enough amniotic fluid, right? When there's truly not enough amniotic fluid, every time the mom has a contraction, the baby would have a deceleration. We saw that with the late decelerations that we studied earlier, right? Late decelerations. We don't have that here. The baby is not distressed. So the small amount of amniotic fluid isn't because there's not actually enough amniotic fluid. The small amount of amniotic fluid is there because she's leaking amniotic fluid, right? So amnioinfusion here is not what you need to do. Right? She has oligohydramnios. Amnioinfusion is not really going to help at this point. She's going to be fine. The baby's actually okay. As we could tell, the baby is okay. You do amnioinfusion for the baby's management, and the baby is okay. There's nothing wrong with the baby. Moderate variability, multiple accelerations, no decelerations, heart rate is 140. That's all looking perfect. No amnioinfusion necessary. And then with the tocolysis, well, the contractions that are occurring are necessary here, right? Because they're what indicate to us whether or not the baby needs to be delivered ASAP. If you give tocolysis, you're going to be covering up one of the key symptoms that are going to tell you whether or not you need to do delivery right away. Right? Premature rupture of membranes or preterm premature rupture of membranes are all things that tell you, figure it out. What are you going to do, doctor? Are you going to keep the baby inside and help the baby develop a little longer while making sure the mom is not at risk of anything? Or are you going to deliver the baby right away because maybe the mom is at risk for something? To figure out whether or not the mom is at risk for something, you need the contractions to be occurring. Once the mom is at risk for something, her contractions will start occurring a lot more and you get the baby out. Right, so you can't cover up one of the key symptoms you're using to figure out what you're going to do. Right? So those two answer choices, although reasonable, now you know why they're not things you can do. Right? So that's kind of what this table is great for. This table here breaks down the time, and then after that you figure out whether or not there's major complications. If there's no major complications, you just go with the uncomplicated list of things. For our current question, the answer was just using latency antibiotics. So that's it for there. In the next video, we'll wrap up the rest of this and then look at puerperium.